neo means new. In this regard, anti-neoplastics is the broad term for medications we use to stop cancer or to treat cancer. We'll talk more about that. Neo means new. Aplasia is abnormal growth of cells, abnormal function of cells, where they don't belong, where they're not serving a purpose. Normal cells, your non-cancerous cells, have distinct appearances, distinct functions. They know when to start dividing, they know when to stop producing. They have specific functions, so they work exactly like they're supposed to. Benign tumor cells, they don't wander, they don't invade, but their growth is not needed. So that is like the place of biology. And you don't need to know the functions that I just went over. I'll go back if you want me to, but just to know that your cells are, when to grow, when to not produce, when and how to behave. So normal. Benign is they have a lot of the features of normal except the fact that they are not needed. Again, using the word, I would not use the word tumor with your patients if we're talking about benign issues, because tumor often equates to the normal for the person that's not healthcare. It means cancer. So if you have a benign tumor, that's going to right away, most people think that means it just told me I had cancer. Cancer cells, on the other hand, are much different than that. They don't know when to quit producing. They divide rapidly. They invade. Their chromosome design pattern is messed up. All the other characteristics that we just went over with normal cells are not there. That's the problem. So we talk about primary and secondary tumors, as I'm sure you already know. We always continue to refer to that cancer by its origin. So if you have breast cancer, it metastasizes, we still diagnose, the primary diagnosis for that patient would still be breast cancer. It doesn't change into now primary diagnosis of lung cancer, if that makes any sense. The original cancer is how we take it from there, and then we talk about where it's metastasized to. Grading, it's important for you to know this one. Grading is the difference between how much it looks like its parent cell or not. So grading is, we talk about well differentiated. It looks a lot like the parent cell. That's good. It means it's not divided and gone rampant. We call that well differentiated. That cell looks a lot like its parent cell. So it's not taken off on itself and gotten completely morphed into something different. When we talk about cells that are poorly differentiated, they're way off from their parent cell. Not good. So you take a picture with your phone and you send that picture from your phone to your friend, it's going to probably look a lot like the original photo. You took a nice photo on your phone, you sent it to her and she got it. But if she takes it and she does a snapshot of it, and then she emails it to someone, and then they take it from their email, and they put it on a copier, that photo is going to get way off from the original photo. That's what we're talking about. So when you're grading a cell, if you're looking at a cell, you're going to analyze how close it is to the parent. The more off from the parent, the more it's divided and done its own thing. Probably the poorer prognosis and the worse things are. Does that make sense? So again, we give them grades when we classify cancer cells. You don't need to know the difference between G1, G2, D3, or G4. What you do need to know is what grading means, and when we talk about a well-differentiated cell, how does that compare to a poorly differentiated cell? That's what you need to know about this slide. You don't have to differentiate between all the rest of this. Very good. Staging is different than grading. Staging, as we're probably familiar with already, is when we break down and we analyze what the cancer is, relationship to the tumor that's present or not, has it spread in lymph nodes and has it metastasized. And we score those with a T score, an N score, and an M score. So this is T and M staging. This is staging, not grading. Grading is what we talked about with the parent cell look-alike. Staging is T and M. X is that it can't be found. 0 is there's no evidence of that, or X means it can't be measured. IS means that it stayed localized. If you get that kind of a staging score, IS. And I like to think about that as in the situation. So you're sort of localized. And then T1, 2, 3, and 4. A T2 score does not mean you have 2 tumors. A T2 score does not mean you have a 2-centimeter tumor. It's a range. So a T1 score means that your size tumor is smaller than a T2 score. Smaller than a 3 and a 4. So if you're analyzing the T score, don't say that a T2 means 2 tumors. It does not. Or don't say that a T2 means 2 centimeters on your tumor. But what you can interpret is that a T2 score means that that tumor is more extensive than a person that has a T1 score. Same thing for the N score. So, N means that it can't be measured, and 0 that there's no indication that there's no involvement, and then N1, 2, and 3. An N2 is more involved than an N1 is. The M is metastasis or not. So would you all be able, if I gave you a staging score, would you be able to sort of do that interpretation, what I just did? I haven't practiced one that I'll do after bed to help you figure out for sure how that might go. That's staging. And as you know, sometimes people say, oh my gosh, I got stage 4 cancer. That doesn't always necessarily mean that they're going to have a poor outcome than someone else. You know, there's thousands of treatment plans, there's lots of scenarios that give you different staging scores. Carcinogen is things that cause cancer. Genesis means to generate, to begin, like a generator you use at home. The first book of the Bible is Genesis. So carcinogenesis means anything that causes cancer. There's lots, as you can see and know already. Chemical, there's physical carcinogens, there's viral ones. This is a mnemonic that's often used to know different warning signs of cancer. This is a good patient education piece. This is a good community awareness piece. So you're a nurse and you're teaching a community wellness class about signs of cancer. So the mnemonic CAUTION is often used to kind of help patients or help you as a nurse sort of narrow down all the different indications that may be suggestive of cancer. And these next slides just spell those out. Okay, risk factors. The single most risk factor is just being older. So your cells have had to behave and divide correctly for years and years and years and years. BRCA1, BRCA2, we already talked about with the reproductive discussion. And then there's primary prevention, modifying, removing at-risk tissue, and sometimes we'll do chemo prevention, as we also talked about during reproductive. No, you don't have cancer, but we're going to do things to give you something, maybe chemo, to prevent those abnormal cells from converting into cancer cells. Chemo prevention. You don't have to know this slide, but there are definite vaccines that are continually being produced, researched as to what we can do to prevent cancer, as you know. So within your career as a nurse, you'll probably see lots and lots of changes in, hopefully, management of cancer patients. If I'm buzzing through these quickly, you don't have to know them for the sake of learning them for this particular content. Any questions of what we just went over? What would probably be the most important parts of that section just now?
Staging.
Staging.
And the grading.
What are the three parts of the staging score? T, N, and M. Tumor, lymph node, metastasis, correct. If I give a score for the T score of an IS, what does that mean?
Situ.
Right, it has stayed local, it hasn't spread and divided, correct. Grading, that would be important for you to know as well. What does that mean? If I'm grading how much it looks like the parent cell. Poorly differentiated, what is that? How is that different than well differentiated? Correct. Poorly is bad. It's not, doesn't look very much like its parent cell. Well differentiated means it looks a lot like the parent cell. Better for that. Everybody good? Okay, as you know, we'll go over side effects of chemos. If I have a med specific, I need you to know, I'll let you know. We could be talking about a long time about all the different chemo meds. When you're going to give chemo as a nurse, you will go through a specific chemo class to learn all those chemo meds and all that stuff to much greater detail than we can ever get into here. It impairs your immune system, as you already know. People have a lot of GI issues with cancer, nerve issues, lots and lots of body systems involved. This part is important for you to know. This slide is important for you to know. Given a surgery, do you know what type of surgery that it is? Ask yourself, what is the goal of the surgery? So prophylactic, as you probably already know that mole on your back is not cancerous, but I don't want it to turn into cancer, so I'm going to take that mole off. I'm going to do something prophylactically. Diagnostics is as it says. We're going to take a look and do a biopsy to see what our findings, if that's cancerous or not. Cure is that, you know what, your tumor's well contained. It has not grown fingers. I think that today in surgery we can actually remove the tumor, and we'll probably just remove completely all the cancer that's in you right now. Cure. Control is that I'm going to debulk that tumor or that cancer. I'm not going to cure it. I'm probably not going to get rid of all of it, but we're going to try to keep it under control. Removing some of the tissue, removing an organ, whatever it is. Palliative, if the goal of surgery is to improve your quality of life, that's the category that would fall into. I'm not going to cure your cancer that's on your spine. I'm not necessarily going to scrape away tissue to control it, but I'm going to try to help you be able to have less pain in your spine. If that's the goal of surgery, that's called palliative. Or I'm going to improve your movement. I'm going to remove part of your cancer in your arm so you have better range of motion. Is it going to improve this quality of life? It is. It's going to fall into the category of palliative. Second look is as it says. Second look is that we've given treatment. Now we're going to see what's going on with that cancer. And then reconstructive is pretty self-explanatory. So if you had to identify what type of cancer treatment the patient's undergoing, ask yourself, what is the goal of surgery? You see the documentation that this is what we're going to do with surgery today. Your patient says, well, I'm having surgery today because the doctor said if they're going to completely remove the tumor, he thinks it's going to get all of the cancer out, then you know that that means that he's going to have a surgery that's curative. Ask yourself, given that scenario, what's the goal? Radiation, that's beaming from the outside. As you know, there's lots of cancer treatments, different forms, different sequences. Sometimes we radiate before surgery, sometimes we do surgery. So you can tell your patient, your friend Susie had it done this way, there's all combinations of recipes for cancer treatment. It'll be individualized to you. But what you do need to know about teletherapy, the patient is not radioactive. There's no source inside of him that's radioactive. It's beaming from the outside. He is not hazardous to someone else because he's not walking around with radiation inside of him. It's beaming from the outside. That's called teletherapy. That umbrella term. Tele means across. So telegram, telephone, telecommunications. So tele means beaming from the outside. That's how you're destroying that tissue. So he is not radioactive. And radiation therapy, kind of like you're getting sun exposure when you're laying out in the sun. There's a lot of combinations of the amount that's going to get delivered and the dose and the time it's going to get applied. There's lots and lots of things that play into the treatment plan for that. And these are the different forms. You don't need to know the differences between this one, the next one, the next one. But if you see this written in a chart where a patient's undergoing that, you kind of have an idea, oh, all those things fall into beaming from the outside umbrella term. This is an important slide to know. The site that gets radiated oftentimes gets very sensitive, gets blistery looking, gets inflamed. So that's an important part of your teaching. And the bone often gets brittle in that area as well due to radiation. So your patient teaching, if your patient has a site that looks like that, is when you get done out of your shower, pat dry it. Don't be rubbing hard on it, right? Don't put any harsh lotions on it. Actually, don't put any lotions on it unless they're prescribed to you. I don't want any nice smelling Bath and Body Works lotion on there. Stay away from sun exposure. Think about the last time that you had a really bad sunburn that perhaps looked like that. How did you manage that? I want you to stay hydrated. I'm going to be aware that your bone is going to be more brittle in that area. You may have hair loss in that scarred area. You obviously won't have hair loss because we're not giving you chemo. But if any of you have ever had a scar, some of you recognize that the hair doesn't grow back. If you ever had a scar on your head or an area that has on your arm. So hydrate. Careful on the no rubbing on that, nothing harsh on there, nothing but prescribed lotion on there. Take really good care of that area because it is sensitive, it's blistery, it's sore. No direct sun exposure. Your patients will have sometimes markings. Don't rub them off. That's the blueprint for radiation. In pink, which probably the arrow should have been red. No direct sun exposure during your treatment and for at least a year afterwards. Again, vulnerability to fracture due to the bone becomes more brittle in that area. Hydrate. Just like think about the last time you had a bad sunburn. Questions about teletherapy. Is he radioactive or is he not?
No.
He's not. Okay. Different than brachytherapy. The umbrella term of brachytherapy is that he has a radiation source inside of him. Knowing that he is radioactive and he can emit that to you, and he is hazardous to others. Different than teletherapy, which is being used outside. Brachy is he has a radiation source inside his body of some sort. So, yes, you're going to be radioactive. The question is, are your wastes going to be radioactive or are they not? The waste products will be radioactive if that radiation source is not sealed. So I gave that patient a PO radiation medication today. When will that radiation be out of his body? I gave it to him by mouth. After the half-life, after he's cleared that medication out, right? I gave you a last pill today, doesn't mean you're done being radioactive this morning. Think about the last time you took an antibiotic. You took an antibiotic today, but your urine still smelled like antibiotics for hours after that, right? Because your body is still clearing that antibiotic out of there. So if it's unsealed, as in it's got to go make its way through your urine, your wastes are going to be radioactive as well. And it's going to be radioactive until that medication has cleared out of your body. Which typically, if you looked up the half-life, you could probably figure out exactly how long that would be. Typically, we tell patients 24 hours after your last medication. But you as the nurse, recognize that he is radioactive and recognize his waste products are going to be radioactive in these circumstances. Or if I've instilled something that's sloshing around in the abdomen, it's not sealed in some little capsule, how does he get rid of that radiation? He still has to urinate that out, right? So he is going to be radioactive, his waste is going to be radioactive. Everybody good on that? Different scenario for this patient. He has a sealed capsule that contains his radiation that has been implanted in there by a healthcare provider. It's been inserted into the uterus. Is he radioactive? Does he have a radiation source inside of him? Yes. Oh, I should say she. I gave you the uterus scenario. Just so you paying attention. She is radioactive. Are her wastes radioactive?
No.
No. Because do her kidneys have to get rid of that radiation?
No.
Does it peed out correctly? When is she done being radioactive?
When that comes out.
When they come and take that capsule out of her body. You guys good with that differentiation?
Yeah.
So she's radioactive, the radiation source is inside of her. Her kidneys are not going to void and pee that radiation out. It doesn't process through the kidneys. She's done being radioactive today when the healthcare provider comes in, removes that capsule. She's done being radioactive. Her waste products have never been radioactive. You are going to need to know the safety and differences between this one and the one we just talked about. It'll be clear in the description as to which is which. Anytime a patient is radioactive, these guidelines go into place. These guidelines go into place anytime a patient is radioactive. Safety is always your priority. Safety is always a priority, and it probably will be a priority on your test next week as well. So given this scenario, is the patient radioactive or is she not? Are her wastes radioactive or are they not? If she is radioactive, what kind of guidelines are you going to give, instructions are you going to give to your visitors or for your care team? Why do you wear a dosimeter as a nurse? Correct. How much you've been exposed to. It doesn't prevent you from getting radiated, but you all have your individual dosimeters sitting outside the room, and we're keeping track of how much radiation you got, how much you got, how much you got when you gave care to your patient. Keep all linens in the room until the patient is done being radioactive. We don't want you carting linens in and out of the room, especially if your wastes are radioactive. Maybe they've been incontinent, maybe there's a little bit of urine on some of the linens. Leave it all in the room until you all are done with being radioactive with that patient. And gather your activities, kind of bunch them up as a care provider. If you have a shield, lead shield, it goes between the door and the patient. We're always trying to protect the patient from emitting radiation to everybody else out here. No young visitors, as you can see on the guidelines. No pregnant visitors. We don't want anyone else getting exposed to the radiation that causes it. So yes, you'll need to instruct your visitors or instruct your staff or know for your own sake, how do I give care to this patient that's radioactive? So I follow these guidelines. Nobody, if you're trying to have a baby, you think you might be pregnant, you would not want to take care of that patient. Because you do not want to expose might damage your hearts, or you might damage the baby if you are pregnant and don't know it, or if you are pregnant.
Would they be infusion while they're out?
It all depends, not necessarily. Yeah.
So it's like they.
It's all over the place.
Thought of this at home too.
Correct. Yep, that's a great question. Because, you know, obviously if you took a radiation pill, you probably would not be sitting there as an inpatient. You'd be going home, and yes, absolutely, all these guidelines go in place. Questions about what I just went over. So knowing what teletherapy means, patient instructions for that, patient education for that, person undergoing teletherapy, we've already talked about the name of that site. Brachytherapy, what that means, which type means that you're gonna be radioactive and your waste products are gonna be radioactive, which type means that you're gonna be radioactive but your waste products are not gonna be radioactive, and visitor staff guidelines for safety. Questions about any of that? Okay, this category of meds is anything used to treat cancer. So it can be antibiotics, it could be chemo, it could be lots and lots of different kinds of medications. Neoplasm, again, break the word down, means a new tumor. You don't have to know how all these things work, but it's super cool. I don't know who's smart enough in the lab to figure out how to make all these medications work. Some of the medications change the way the DNA is made up. Some medications change the way the whole thing's metabolized, cell division. Some changes the formation of the cells. Again, some mess with the DNA. You can spell that first word, you can get extra credit points, not kidding.
Yes.
So as you can see, there's lots of ways that medications work. This is sort of the latest thought, dose-dense therapy versus dragging out chemo for 8 weeks. We try to get you in here 3 times a week and hit it hard for a short amount of time. That's called dose-dense therapy. Assuming your patient can handle the side effects and then your labs and all that stuff. But you hear that terminology, that's what that means. We try to hit it harder for a shorter amount of time versus a longer amount of time, less dose. But sometimes patients can't tolerate it, you probably know. Lots of ways we can give chemo. In red, pink, in bold. You're only allowed to give chemo as a registered nurse if you've gone through an approved chemotherapy program, according to the oncology board. You can monitor a patient getting chemo, but you can't initiate and start that new idea if you've not been through a certification course. We had an interesting discussion in clinicals, after clinicals Monday. The student was talking about the fact that they were allowed to do something that wasn't. The institution they worked for allowed them to do a certain procedure that wasn't approved by the board, but the hospital said, we got special permission to let you do it. It's not really approved by the board, but our policy says that you're allowed to do this procedure because we have special permission. And that doesn't make sense to me. If I'm the administrator and the board says you can't do it, why would I go through the process of getting special permission for you to do something that the board says you're not supposed to be doing? So that's my take on that. We had a little discussion. The student goes, well, I just said I'm not going to do that because I don't feel comfortable since you just told me the board doesn't allow me to do that. If you're an administrator, I would not, if the board says this is the rule, I'm not sure why you'd ever go against that, right? I just think you're taking a chance, a big risk, but I'll get off my soapbox about that, probably won't. Stick up for what you know is right. Look into your scope of practice. If it doesn't feel like it's right, look into it. If it's not right, you're not allowed to do it, you're not competent, you don't feel good, comfortable doing it, speak up. It's your license on the line. It's the patient's safety on the line. You work too hard to get your license to say, well, I should be doing it, but I'm gonna do it anyways. Speak up for yourself, protect your patient. Okay, everybody clear on this one? Okay, this is important. This is an emergency. This is something that you're going to need to know for sure about. What this means is that you've got your highly toxic chemotherapy you're giving So it's eating the tissue in that area because that IV is not in place. You can prevent this extravasation. You can prevent it. And you can say, well, I can't really help an IV getting infiltrated. No, you can't do that part, baby. But what you can do is to monitor your IV site frequently. To prevent that, as soon as it becomes infiltrated, get that out of there so it doesn't start eating the tissue away around in that site. And that includes answering alarms frequently. You know what, while you're getting your chemotherapy, Mr. Smith, I'm gonna have your bed turned this way so I can see your hand every time I walk by your room. I'm gonna ask you to please have your hand outside your bed sheets while you're getting your chemo. Because my job is to really keep a good eye on your site. As soon as you feel something abnormal on your site, please put your light on. Because I do not want this to go outside of your bloodstream, and I don't want to start causing problems with the tissue that's around your IV site. So you're the nurse. This has occurred just by the way it happens. Your job then, obviously, is to take that IV out. If they have an antidote, sometimes we have an antidote for chemotherapy. It comes with a little sub-Q needle, and you can just inject the antidote around that site to try to prevent that tissue from getting eaten away. So have an antidote kit in the room if there's one available, and cold compresses, warm compresses, depending on what you need for comfort. That's your treatment plan for that. So you don't end up with a hand that looks like that. I have the lights okay in here. Do you need to change these at all? You don't, you do just holler. And as you know, more that gets eaten away, there's lots of potential problems that could occur. Know what you're doing when you're doing chemo. Pay close attention and don't let your patient reset their alarms because they're trying to sleep. My mother-in-law's husband said that one time he was in. He wasn't getting chemo, he was getting something else. Yeah, the alarm was driving me nuts, so they told me how to reset this pump over here, so I just reach up. I have to sometimes, I just hit reset, do it, I'm like, oh, like, don't keep doing that. And do not put something tight, Coban, a tight wrap on that side. You guys at clinicals are probably tired of hearing. That's too tight and doesn't allow you to view the site, right? It makes no sense. It can be prevented. Questions about that? Yes, it's critical. Yes, it could be a potential emergency. Yes, you're gonna need to know that for next week. Students have asked me, how do I know how to start studying for the final? Emergencies, crises, life-threatening situations, they'll all be on there in some format. Guaranteed. Because no matter what setting that you're in, you may encounter that problem or situation. So if you're trying to sort through what to absolutely start studying for, what to flag and tag in your notes, just start going through there and ask yourself what kind of falls into that category. Okay, you're giving oral chemotherapy, including your caregivers at home. You need to either wear the specially designed chemo gloves or at least double glove. Because you don't want to get yourself exposed to the chemotherapy either, because you're the caregiver and you're taking out of the packet and giving it to your patient. Education for your families and caregivers is absolutely critical. So either double glove or chemo glove, gown, masks. We want to protect you as well. Don't change the format of oral chemotherapy drugs. If the patient's got an NG or some other situation, collaborate with your pharmacy to see what else are options for you with that. Side effects related to chemotherapy, as you know from having people in your family, people you've taken care of, there are lots. One big issue is bone marrow suppression. It destroys circulating blood cells. It's not just, oftentimes it tackles the cancer cells, but also tackles all the other cells that's going on in the body. Back to that for a second. So you're going to have decreased white blood cells. And the nadir, N-A-D-I-R, is the rock bottom point of low blood cells. It's called nadir. For chemo today, your white blood cells are going to be at their lowest in 7 to 10 days. That's just the way it goes. So if you give your patient chemo today, and you say, okay, tell me about what you're going to do in the next week or so. What kind of restrictions will you give to him, knowing that his white blood cells are going to be rock bottom lowest in another week?
Can you grab whatever you were?
I sure can.
Yeah.
See, I like my whiteboard right here. Like, can you tell? Like, you're like, it's right over here. I like it right there, so I can just write it anyways. I'll put writing. It's called N-A-D-I-R. That means rock bottom low numbers. So white blood cell, the lowest they'll be after chemotherapy will be 7 to 10 days. So what do I want to know about what you're doing a week from now? Related to that specifically. You're going to be severely immunocompromised in 7 to 10 days from now. So what kind of restrictions am I going to have you implement?
Stay away from crowds.
Correct. So knowing your white blood cells are going to be lowest in a week from now, just by the way chemo's designed, I don't really probably think it's a good idea for you to go to church in that time frame to go, tell me what your activities are. I can't wait to go to Thanksgiving in a week from now.
Stay away
Okay, let's
from
have a full conversation about that. Who does that involve? Because your white blood cells are going to be at their very lowest, all those things that are going to increase your risk of getting infection probably should be restricted. The lowest red blood cell count, erythrocytes, is in 2 to 3 months from now. Erythrocytes. So what do I know, what am I going to figure out with my patient related to that time frame? Red blood cells bottom out 2 to 3 months after. How is that going to impact my patient in 2 months from now? What do I have to restrict or be concerned about if you have really low red blood cells? Not necessarily that. What happens when you have low red blood cells? You have low hemoglobin. What's your tolerance to activity when you have low red blood cells? Correct. So tell me about, do you have any vacations planned, anything in a couple months from now? Well, I have a weekend away planned. Okay, tell me what that's gonna look like. Well, we're just gonna chill in a hotel room, my spouse and I, and we're just gonna take it easy we're just gonna go to Indiana. Okay, that's probably okay. Tell me about your vacation. Well, in 2 months from now, we have this big hiking trip planned, and we're gonna go out west for 3 weeks. Okay, you probably won't be able to tolerate that much activity. Your red blood cell count is gonna be really low at that point in time. That's the teaching and education that needs to go with that knowledge. And I can attest to that because, again, my mother-in-law's husband had multiple myeloma, got chemo around here at Christmas. We went to their place in Florida over spring break. And we get there, and the first thing my mother-in-law says is, oh my God, he's gotten so lazy. He's watched me wash the car, he washed with me. Well, what's going on with red blood cells when we were there on spring break in March? He got his chemo at Christmas. Low. So what kind of activity level and tolerance does he have? Minimal, right? No one really recognized that was going on, but he was just tired all the time. Well, that's because his red blood cell count is really low right now. And that's why he does not feel up to doing anything like that. So your job as a nurse is to recognize that, to get a good information from your patient to find out what they have planned ahead, and can I help you? Because I know for a fact that this is when your numbers are going to be low. Platelet count, the nadir for that one is 7 to 10 days after chemo. Don't mix those two up, we just talked about that. 7 to 10 days after. So what kind of history or what kind of information do you want to talk to your patient about with that? Pardon me? Bleeding risk. So what are you gonna find out I'm doing in a week from now on your patient? What kind of activities are you
Risky.
planning for the next
What risk behavior?
7 to 10 days
Risky
out?
activities.
We always have an annual family football.
Oh.
Like football.
Yeah, don't do that.
Do you play football? Yeah, I usually do. Okay. This year, knowing that your platelet count's gonna be really low. Correct. I got the shaking head no. This year's not gonna be an option for you to actually play football. Because a slight injury might cause you to have really increased bleeding because your platelet count's gonna be really low. So I don't really want you doing physical activity when I know for a fact that your platelets are gonna be really low. It's 7 to 10 to 14 days from now.
Should they not be taking out that month because of white blood cells in the blood?
Well, that's another good question. You have a good thought on that. 7 to 14 is probably safer. Yeah, the question we had is, should you even be at the family function because your white count's gonna be low and so are your platelet counts? Good question. How many people does that involve? Are you all in a big room grouped together? Is it outside that you can sit on the bench and maybe wear a mask, not be exposed? Yeah, that's great.
How long should you advise the patient that it's going to take to recoup those red blood cells? Like, is it going to take another 2 to 3 months to get back to?
There's lots of varying factors depending on how much chemo and all that stuff.
Okay.
For the sake of next week, my answer is going to be don't go there.
Okay.
But that's a valid question because, as you know, if I have ongoing chemo, does just keep resetting itself? You know, it's like, in theory, it could, right? I mean, we could always be in a state of decreased counts, depending on your formula. That's a great question. So it actually probably resets every time you get chemo, we're back to the same increment. But for the sake of clarity, I won't give you that scenario.
Okay.
And as you know, but that's a great quality as a nurse. I'm just teasing when I say that. You all, when you critically think through all that stuff, that's great quality as a nurse. When you're a student, just stay in the lane. So, your patient gets chemo today, will be the scenario. And then, okay, I should type it 714, just easy. So your patient gets chemo today, and you want to do what kind of history, or he got chemo and he said, this is my plans for 2 weeks from now. You're like, okay, what goes with teaching with this one, and that one? If you answer that question correctly, that tells me you understand what the nadirs are, you understand what goes with decreased white blood cells, the issues with that, decreased platelets, issues with that. Because we can't say, you're going to chemo for next year, you can't do any of that stuff forever, not for forever. Because that's not realistic either, right? So it's important for you to understand what those 3 words mean, when they bottom out, what teaching will go with each of those 3 counts being completed. Everybody good with that? But you're exactly right. It's not, there's lots of combinations of chemo, and that's why I pay close attention to your lab always when we're doing chemo, to make sure we don't run into this point where you're gonna have problems with even staying well. Or not bleeding, not bleeding to death, or not having neutropenic precautions. Some of you have had that before. That means you're protecting him from getting your germs. Usually, contact precautions, those kind of things protect you as a nurse from getting his germs. And neutropenic is the flip side. He's got a low ANC count, a low white count. You know, he's very vulnerable to getting an infection. You're going to protect him from you. So, if you don't feel well today, don't take care of him today. There's no list of magical equipment you need to wear when you walk into the room. I would always for sure wear gloves and masks. Because why are you breathing on him your germs even if you are feeling well? It doesn't make any sense. So mask and gloves for sure is what I would wear. Contemplate the gown if you, depending on who else you're taking care of today. And we're gonna try to avoid anything else that might introduce germs to you. We used to say no fresh fruits and vegetables. And that's kind of hard to live with, right? You don't stay well if you don't eat fresh fruits and vegetables. So we kind of now differentiate between fruits that are plums and those are probably not a good idea. If a hard apple that you can wash off and scrub really well, it's probably okay for fresh fruit. So just using common sense on some of those things. If I can't wash it well, it's probably not something that I should be eating if I got low immune system. So that's the differentiation now.
I was a nurse and a care patient. You're not allowed to take anybody, taking anybody else's medication?
I would not.
That's what it's all about.
I would not take care of somebody that's got a MRSA over here and then walk into this patient's room. That's a great question. Because that doesn't make sense that you're potentially moving active MRSA over here and walking right into your room next door and taking care of this guy that has no ability to fight off infection. That's a great thought. Now, like I said, there's no magical list of what to wear. Just use common sense as this nurse. Don't feel well, don't go in there. Don't take care of somebody else that's got a bug going on. Your kid's at home sick, don't take care of that patient today. It's not fair to him if you're gonna compromise his immune system even further because you knowingly went in there and, explain that to visitors as well. You really can't fight off infection very well right now. So if you were, I heard you coughing down the hall, probably shouldn't visit today. Okay, low platelet counts, thrombocytopenia, thrombocytopenia's platelets, DM means decreased number of. So we can do things to boost the immune system, transfusions. We can do nutrigens, other immune boosters, platelet boosters. Nausea and vomiting, our goal is to ward that off before you get sick. So a lot of times we'll give them an antiemetic before we even get started on chemo. I know you have got sick previously, but we don't want you necessarily getting sick today with your chemo. And we give you an antiemetic. This is going to try to hopefully keep you from having nausea and vomiting after you've gotten your chemo today. Caution. One is an antiemetic on this screen, one is not. Don't mix them up. So you're getting ready to take care of your patient who's getting chemo. You're going to give her an antiemetic. You're going to select which one of these medications to give to her. I remember it's an antiemetic because it's got a Z in it. I don't know why it's A to Z. I'm not sure why that makes any sense, but that's how and it's got EM in the middle of it. EM, which that one does not. So emesis. So EM right there in the middle of the word. Might be a way to kind of get. I said there wasn't much in the way of medications today. This is one. I want you to try to eat some food when your stomach can tolerate it. I know you've been nauseated from your chemo. Just like when you had stomach flu, same concepts. You haven't been feeling well for a while, but I know when you do start to feel better, eat some dry crackers, on your stomach. We're going to try to do some of this. Treating mucositis, those who all learned probably prior to this. Something's going to irritate the mouth. Hair loss, it's temporary. It grows back in sometimes different color, texture, thickness. There is some success with cold cap therapy. So patients will go for cold cap therapy treatments before they start to get their chemo. And it changes the follicles and it convinces the follicles from, programs the follicles to not have hair fall out during chemo. So patients have evaluated, like I said, it's got some success. So it might be something when you're talking about planning chemo ahead of time. There is this concept that's called cold cap therapy. It works for some, it doesn't work for others. But if you're concerned about losing the hair on your head, some patients have had good luck using that therapy. I don't know that it's covered by insurance, but I don't even know if we have expense there, but I know that tracing, so that's actually a thing. And you're like, oh my gosh, I just can't think, well, yeah, that kind of working with neuropathies. You studied those a couple weeks ago with neuro. I'm not going to spend any more time on that. Preventing injury, always, of course, safety, safety, safety. Sometimes we do things that modify the messaging and increase inflammation. We went through that when we went through rheumatic disorders weeks ago. Again, you don't have to know these, but there's lots of ways that chemo works. We have targeted therapy, it's less severe on the normal cells, right? It just hits the cancer cells. We've got signaling that can get inhibited, stopped. We can boost growth factors. So as you can see, there's lots and lots and lots of things. You can study these in more detail when you have nothing better to do with your time. You can change the hormone feed, which we were talking about during reproductive. Side effects, we already covered that during reproductive. I'm going to cover that again today. Okay. Questions on that? So probably for that, what you need to know most importantly is what we talked about, the low counts, when they're going to be low, what those words mean, the implications for your patient when he's got a low platelet count, what's important information for you to take in and know and talk about with your patient related to those rock bottom days, numbers, months, all that. Side effects, managing of those, just generally speaking.